So Dr. Ryan Martin, like I have heard nothing but great things about you, truthfully. But what's shocking to me is I've never heard anything about you until I got on LinkedIn. I got on LinkedIn, and that was the first time I was introduced to musculoskeletal ultrasound. That's the first time I was introduced to you, your content, your courses, your coaching, all the stuff that you do. I've got to ask, like, are you not as active on other social media platforms? Is LinkedIn your main resource for people to find you?
Yeah. So, well, first off, thanks for having me on the show.
Of
I've
course.
watched quite a few of your shows, and I love what you're doing. But for me, LinkedIn, it's just something that I started. I was never a social media person to begin with. I didn't know anything about anything. You only know what you know. And I started on LinkedIn, and I had one follower. And I think it was probably a family member at the time, and slowly just started adding content, and that's kind of where I stuck. I mean, I made an Instagram account, but I'll be honest, like, it's mostly crickets.
Yeah.
And then after watching some of your shows and stuff like that, YouTube might be my next forum that I try and tackle, because I mean, you're crushing it. And you give me inspiration to move past LinkedIn, but as of right now, LinkedIn is my go-to.
It's so funny because I didn't even consider. I first got on Facebook, and I was creeping in the groups. This would have been like 2016. I had no idea what was going on. But I would, answer questions and start making connections. And then I got into YouTube probably 2017, 18. And it was literally a year ago. I got on LinkedIn because I was like, there's got to be a community here that I'm missing. And little by little, I'm growing my connections, is what they call it there, which I like better than friends. I hate calling everybody a friend. I like connections. And so LinkedIn's been awesome. But okay, let's cut right to it. You've opened this whole new world to physical therapy for me. I don't understand any of it, and I hope to just pepper you with questions so I can understand what this is exactly. And I don't even know if I'm saying it right. So I'm going to say musculoskeletal ultrasound, diagnostic ultrasound. Like, what do you call it? How does it work? What are therapists doing with this? Because I just don't know enough about it, and I want to learn more.
Well, from the bare bones, from the beginning, yes, musculoskeletal ultrasound is probably the most correct way to say it. A lot of people say MSK
Okay.
ultrasound. And so, what is MSK ultrasound? Well, we've understood imaging from an ultrasound perspective for many, many, many years. For nearly 70 years. Understanding the physics of ultrasound from diagnostic perspective. And we've also heard of, oh, I look at babies, I look at thyroids, I look at kidneys. But there is a scope that we can look at muscle skeletal pathologies, right? And so we can look at rotator cuff, hip pathology, knee pathology, things like that. And I always tell people is, well, who would you want reading that? And this is kind of plays back to the physical therapy role, is who is an expert at, muscle skeletal anatomy, and who understands biomechanics, and who also has training in differential pathology. So if you kind of add that all together, I thought it was a great idea for me to step into this, because it felt like that was a role, that was something that not just, myself, but more PTs need to utilize this concept. So that's what MSK, musculoskeletal ultrasound, is. It's a diagnostic ultrasound, not to be confused with a therapeutic ultrasound. And there's a lot of differences between the two. So that's what it is. And yeah, you're saying it right.
Okay. And what are therapists doing? Like, so somebody who goes through your training program, are they doing this as kind of a side hustle? Are they doing it to supplement or improve their actual patient care experience in the clinic? Are they doing it for orthopedics? And I mentioned to you before the show, I've got a local non-surgical orthopedic. He's a sports medicine guy. Love him to death. We've known each other for years now. He will do, and he says he prefers the musculoskeletal ultrasound in his office when he can, but he doesn't always have the time. So like, how are therapists using these skills?
Well, I guess one of the best ways to say it is in conjunction with your current practice. not in lieu of, not necessarily a side hustle, things like that. It's something that streamlines directly into patient care. So imagine if a patient comes in, they have a hurt shoulder, say they've had it for a long time, you come in and you're doing your evaluation, you're doing all your tests and measures, you're doing your history, all that kind of stuff. And you're thinking to yourself, this seems like a supraspinatus strain of some sort, right? But I don't know the whole extent of it, and there's other extraneous tissues around there that might be involved. Well, during that evaluation, right then and there, you can have a bedside machine that you can do MSK ultrasound diagnostically, and get a clearer image, a clearer picture of what's going on there, and not just what's going on from a pathology, but what's the extent of that pathology, and does it warrant your algorithm? Does it warrant, hey, this patient's great for conservative care, or this patient is a referral base, whether it be like your friend that you have non-surgical orthopedic that can do possibly, I would imagine, orthobiologic regenerative type practice. Yeah.
Sure.
And so you could refer for there, or you look at it and you say, well, you know what, this patient, from all my tests and measures, from my history, and from this image, this person has no supraspinatus whatsoever. Maybe that's a discussion that you have a good referral source to an orthopedic. So it helps set the basis of your algorithms of treatment, right then and there. And so it gives you a better idea of, all right, where's this patient going and what is going to be their overall, um, treatment, algorithm. So that's kind of how we see it, and that's how we teach it. We don't just teach MSK ultrasound. In fact, I think that sounds, I don't want to be rude about it, but I think a lot of people can teach MSK ultrasound. The nuts and bolts behind it is, how do you integrate that into a practice, right? And so that's where we really strive. Like we actually do a lot better, is actually educating both physicians and PTs and anybody that's within the realm that can do MSK ultrasound, is how do we blend that? How do we utilize that in practice? And what do we use it for? It's not an end all be all. And I want people to understand that right away. Is I'm a clinician, first and foremost. I understand my treatment algorithms. I understand the importance of a good clinical decision based on your history and examination. And this is a tool that helps move that forward and helps create maybe or possibly new avenues that you could use with your referral sources.
Now, most of the people who would watch this podcast, this episode, they're going to be smaller, independent, private practice owners, clinicians that are operating by themselves. Is this something that they're shouldering the cost and they're just doing it because it makes their patient experience better? Or is this something that they're using to generate additional income, whether it be cash pay or potentially insurance reimbursement?
That's interesting that you say that. About 2 months ago, our company did a webinar called ROI. So the
Yeah.
return on investment with MSK ultrasound. And we really kind of broke down, okay, is this just something that's going to make improved patient care? Well, yes, we can all agree on the literature to support that. But is there a way that this also makes financial sense? Well, yes, there is a financial backing to this as well. And I was on a recent podcast, and that was one of the questions is, well, what does it reimburse? And to that, I answered, well, you know, if you're only worried about the reimbursement, you're looking at this at the wrong way, because MSK ultrasound can open so many other avenues for that discussion with your orthobiologic doctors, with other referral sources. This is a great marketing thing. So beyond just that, code that you can get reimbursed on, I mean, this is something that creates other value, to your clinic. So if you're just trying to make, dollars on it, then I think that's the wrong way to think about it. But if you're trying to improve patient outcomes, and again, remembering know, like, and trust, if you build better rapport with your patients, and this is one more contact point with your patient to help improve that trust level, then you've built more rapport. And who is your best referral source, right? A lot of the patients that come into your clinic are going to be the next ones that tell their mom, their dad, their cousin, their neighbor. And so this, if you look at it from a broad perspective, that's where the financial incentive comes from. But more importantly is the patient care.
Let me ask you this, because I was thinking about you yesterday. I saw a patient. Patient had sustained a radial fracture and had developed some secondary problems in the rotator cuff. The original bone fracture was secondary to falling off a bicycle. Potentially the shoulder injury was sustained at the fall, or it was something that developed through use of the sling and other stuff. This particular patient wants an MRI. Now, in my clinic, everybody that comes in, I would say there's a fair number of people who come into my clinic kind of upset, saying, my insurance company refuses to pay for my MRI until I receive. And really, when they say receive, they mean until I fail physical therapy, so that I can then get my MRI. And a lot of them will say, how can you treat me as a physical therapist if you don't know what's going on, if I haven't had an MRI? Now, I can go through all the conversation around the inaccuracies of an MRI and how, we want to look at the person and the case history and tell me about your symptoms and all of these things. But that was a long way for me to go back to saying, is this something that I could use in the clinic in a case like this, where the patient wants some sort of diagnostic imaging? They don't have access to an MRI until they do several therapy sessions, usually 6 weeks. Could I do an ultrasound to look at the tissue? In this case, it's a shoulder specifically, but I'm also curious about like low back issues, knee issues, other stuff. Um, and within that, well, first that, like, is this a situation where somebody doesn't have imaging yet? They want imaging. They specifically come to me because I could provide a different form of imaging.
I think you basically nailed it on the head. That's the exact type of scenario where you'd want to do this, where you can expedite some of the information, that would help create a better environment for treatment, right? And so I think you kind of like summed it up right here. Is okay, is this something that was resultant from the fall? Is this something from biomechanics afterwards, whatever it may be? Remembering that MSK, or muscle skeletal ultrasound, that's its job. It's going to look at that tissue, and it's going to look at it, at high detail, high resolution. So if you had a patient, and again, I think one caveat or one thing to always kind of disclaim, a little disclaimer is as PTs, is you have to understand your practice act, right? You have to understand what you can and can't do first off. So if this falls within your practice act and you have, good training in this is something that your exact patient comes in, you're like, okay, I do see that there's some, limited range of motion, strength deficits, scapulothoracic, things that kind of contribute to that shoulder pathology. So in your mind, your clinical track is already thinking, okay, there's a shoulder pathology, but what is it? Right. And so this would be a great tool to have at the bedside, to where you're like, okay, let's see the extent of this, or let's see if I was right or wrong. So this is both confirmatory, or it could take your diagnosis completely different and say, you know what, the rotator cuff looks great, the bursa looks fine, I don't see any type of, other pathology within this space. All right, what else could this be? So it helps lead to that next level of, clinical reasoning of what this could be.
And what would you say? And I don't even know if this is a question that can be answered, but in regards to accuracy, that's the only word I can think of. What is the comparison? Okay, if somebody is, thinking, do I have a rotator cuff, supraspinatus tear? Orthopedic says, we're going to do surgery. The patient's on board. The patient says, I want surgery. And are we looking at, from your experience, MRI versus diagnostic ultrasound? What provides better image quality or better reliability in the diagnostics?
Well, I mean, you're talking my wheelhouse here. And so I mean, this is what we teach. So when people ask that question a lot. So here's the thing: is we have to try and answer the questions that are in your mind, right? And so when people start asking the same question over and over, it's like, well, what's the sensitivity specificity of MSK ultrasound as compared to MRI? Because they always make that the gold standard, right? When realistically, a scope is going to tell you the true answer of what's going on in there.
100%.
Right, but the thing is nobody's going to go do a scope, as first line defense, that I'm aware of. So if you look at sensitivity and specificity of MRI and MSK ultrasound from a full thickness perspective, ultrasound still kind of squeaks over MRI, because the higher resolution, the dynamic ability So not only can you put that in a position to where the pain is, you can look right at that focal zone. You can test it dynamically, you can test it resistance, you can see if there's what they call paradoxic motion, meaning that, is the tendon moving away from the bone when it should never do that. So there's some telltale signs that tell you that it's a full thickness tear or whatever it may be. And when you compare that side to side with sensitivity and specificity across the board with literature, and I can get you all these if you ever want to link these with all your people, is
Yeah.
that there is literature to support that, sensitivity. We're looking at like the 90, 92, 93, 94, whereas MRI kind of trails in that 90, 91, 92. So they're comparable, but when you think about in the hands of a really skilled clinician on MSK ultrasound, in my opinion, it's even higher than that, especially when you're talking full thickness tears, and this is a surgical candidate. It's nearly like 98% based on literature. So yes, it does have literature. So that's a great question to ask. Now, when you compare it to MRA, so when you're talking about arthrography, if you're talking about using contrast eyes, things like that, then they kind of pull ahead of the MSK ultrasound. But here's the kicker to that is that's an injection based. You have to put something into the patient. That's a contrast. And so is that the first line of defense for something that you think is a rotator cuff tear? Right. And so if you look at like ACR guidelines, things like that, MSK ultrasound is now coming up, pretty strong. So ACR is the American College of Radiology, which is something that we as PT should really understand. What is the algorithms of what these radiologists, what their criteria is? And MSK ultrasound's right up there. And again, not trying to talk too much about this, but you talked about the rotator cuff. Well, that's not the only part in the body, right? So we do have
Sure.
literature to support all sorts of different areas, and how sensitive or specific or how much efficacy we have with MSK ultrasound. So it's not going to find certain things, right? Superficial structures, tendons, ligaments, muscles, nerves, vessels, those kind of things. It's absolutely fantastic at. But we have to remember there's limitations like intracapsular spaces, interarticular spaces. If it's behind a bone, ultrasound signals can't go past a bone. So if you're thinking like a meniscal tear that's deep rooted in the meniscus, you may not see that. But if it's a peripheral tear, you will see it. So again, I'm not trying to go too far
Yeah.
out of line here, but there's literature to support lots of pathologies with MSK ultrasound.
And now you're getting into my wheelhouse. Like I love rotator cuff repair, rehab. That's one of my main niches, but then total knee replacement, both pre-surgical, post-surgical. So if I'm looking, and I would love to hear your experience from my perspective, somebody who's going to see a lot of post-op knee replacements. I also tend to see a lot of complicated post-op knee replacements. So these would be individuals, I'm going to say 6 months, 12 months, 24 months post-op. They're still having complications. They're still limited range of motion. They're still dealing with some things. And this could be anything from tendon ruptures, quad tendon, to other soft tissue injuries. I'm curious about things like ligamentous laxity and like medial and lateral collateral ligaments. What functionality, what use do I have for this kind of technology, if any, in a situation like that, where somebody's had a knee replacement, they're dealing with, frustrations 2 years post-op? Is this something I can use to look at the tissue quality in that case?
Yeah, absolutely. Again, if you're talking extra-articular, outside of the
Yeah.
prosthesis, things like that, if you're looking for extraneous fluid accumulation, if you're looking for tendinopathy changes, especially on the quad tendon, one of the big ones in post-op total knees is popliteus. So can you see the popliteus as it courses across the prosthesis there? Yes. So there's some literature to support a lot of these things that you're talking about with post-operative type patients. When talking about the rotator cuff, looking for the suture lines, looking to see if the anchors are in place, looking again at that term I used before is the paradox of motion. So if the tissue is moving one way and the bone's moving the other way and it's post-operative and say they had a fall, we've had surgeons, reach out and say, hey, we know what the MRI is going to look like. It's going to look like a grenade went off in there. It's going to look like potpourri. We're not going to see anything that we really want to see. And the true testament here is the dynamic ability is to see if those anchors stayed in place, to see if that tissue has stayed stable. And so postoperatively, we have been used from surgeons to kind of look at that, because again, the resolution is so much cleaner than an MRI, especially with postoperative.
Okay. Now I want to hear more about the coursework, but before I do, I'm going to go back to that money issue, that money question, because one of the things that comes up in my practice a lot again, so I'm in Middletown, Ohio, I'm going to say population 50,000 or so, relatively lower socioeconomic area. It was an old steel mill town. The original steel mill got purchased by Cliffs. There's still, a large community of people that work in the steel mill, blue collar, that kind of stuff. A lot of Ford factory workers, GE. So with that, there's kind of a small orthopedic group that's in the area. There's not a ton of resources when they're trying to schedule imaging. They're looking literally, months out, if not multiple months, for this kind of MRI for a rotator cuff, just to see if they're going to justify surgery or not. My immediate thought goes to, could I, and obviously I clear it with the State Practice Act, but could I offer a service just to say, hey, even if your patients don't want physical therapy, but they're going to be on a 6-week waiting list to get an MRI at one of the local MRI centers, could I offer a service direct to consumer that's an imaging service to look at the diagnostics of the rotator cuff, to, at least give them a heads up on what to expect? And if you say yes, my next question is going to be, you mentioned insurance reimbursement. I wasn't even thinking of that. I was thinking direct to consumer, charge them a fee and just get them in, my clinic. I can get them in within 24 hours usually. Is anyone doing it? Do you see any benefits to something like that? And if it is going to be, is there anyone getting reimbursement, or would it be just direct pay like I was originally thinking?
So we need to break that down, right? Because there's some
Okay.
layers in that question or those questions, right? And so first and foremost, is this reimbursable? Yes, there's codes for this. There's two distinct codes that have been used. Yes, you're right. Check out your Practice Act. Make sure this is something. If you were going to use through the insurance, this is something that you would want to probably have a discussion with your insurance. Like, do your due diligence, right? That's what
Sure.
everything comes down to. You can find out what your reimbursement rates are. You can find out who is reimbursing and who is not. So those are the kind of things that you would look into first. And then secondly is, from a cash pay, cash rolls everything around me. That is probably one of the most common ways that I see people implementing this into practice, so they don't have to get into you know, the cycle and all the issues with insurance-based practice. So you could open up that. Now, have I seen PTs open like kind of a standalone service to where they're doing imaging outside of PT? No, I have not. But does that sound like something intriguing to me? Yeah, it does. I mean, to justify the scan, you would probably want to do some sort of evaluation to make sure that it's medically justified for the imaging, right? But I'm sure there's avenues for that exact thing that you're talking about, especially in a community that has a small blue collar, low resource, as far as like there's probably not an ortho or sports med on every corner. This
Right.
would probably be a gap to fill, right? So this would probably be a gap to fill. And again, this opens up discussions with your referring providers on, this is something that I want to offer for your people, for your patients. And I would imagine a lot of them are like, well, we either wait 6 weeks for an MRI, we wait for therapy, we wait for this, we wait for checking all the little boxes that we've been told to check, or we get this right now. And I can't imagine a provider that's referring to you would say, no, you know what, I want my patient to wait. For you, this is building that rapport not only with your patients, but also with referring doctors in the community. It's building a stronger healthcare is what it's doing.
I agree. And from my perspective and in my experience, and I know a lot of clinicians hearing this are going to know what I'm talking about. So when we started here in 2006. All the orthopedics were independent. All the primary care docs were independent. The hospital had a couple surgeons on staff, but generally everybody was independent. Once we hit right around 2010, 11, ortho groups started going into the hospital. And then once we hit like 2015, 16, forget it. They were flooded with cash. They bought everybody up. There's no independence around anymore. And this is what happened back with the Balanced Budget Act in like 97, I think it was. So we know that the pendulum swings. But what's interesting, and everybody therapist wise is saying this, it's so hard to get patients outside the hospital network, you know? So the orthos are under direct pressure to keep patients inside the hospital system. But what I've done, and now I've got really, really great relationships with these guys, all the orthos in town, the spine surgeons in town, because I've been here before they went in with the hospital. I tell people, look, they will refer to me just to spite the employer that is the hospital, because they hate them so much. They want to refer out. But when they can't, if I can bring in a service that the hospital doesn't offer, now that opens the golden doors so that they can refer out. And to your point, we don't want to just be an MRI machine that's doing ultrasound. Like, we want the opportunity to treat and help these patients in new ways. Even those patients that don't think they want therapy coming out to me, they're going to get a physical therapy referral. They'll get the diagnostic to determine what's going on. But that gives me potentially 60 minutes to say, hey, these are the other opportunities we have. These are the other things we can offer. Maybe surgery is not exactly the only choice for you. And I know every therapist listening to this is like, yeah, that totally makes sense. It gives us the exposure we need to those patients who never would have been able to walk in our doors. Any thoughts on that?
I mean, I think you've built in a concept that has a lot of validity in your scenario for sure. I also think that, having the ability to offer this service, as a front line, and again, is it a marketing tool, whatever you want to call it, they're intrigued. They want to know more, right? And this is a service that can be outside of the machine or whatever you want to call it.
Yeah.
And now they get into your clinic and you're offering a service that gives them this hands-on, this gives this discussion based. And now they're building, again, we kind of full circle back to that trust. Now they're building that trust with you. And they're like, wow, I got this information, I feel so comfortable. Yeah, you know what, I kind of want to do therapy, or I want to kind of know what else is offered to help me reduce the chances of XYZ or whatever it may be. So yeah, I mean, I think there's validity in what you're talking about.
Awesome. Let's talk about your education model, because I went on the website today. I'll share it in the show notes down, wherever we publish this video. But you have a couple options. You have like an upper extremity package, a lower extremity, a comprehensive package. Give me an idea of how all of this is structured. Is it all digital? Is it all online? Or are there in-person elements? Is it real time? Or is it asynchronous that somebody could go through the courses on their own? Like, how does this work?
Well, to break it down, we have our website. And on our website, we have all our courses. And you're right, we have it broke down from upper and lower, and we have injection based. So we do train a lot of physicians based on my certification, which is the RMSK, the Registered Musculoskeletal, which is a physicians based examination. You have to learn the injections to take the exam. And so we understand what the injections are. So I don't want people to get confused with I do injections. I don't do injections.
Yeah.
I want people to completely understand is what I teach is where to stick that needle, which means, is there any dangerous areas? Is this the correct area? Do you understand the diagnostics ahead of time? I don't care what you have in the needle. I don't care what your principle was. Whatever that physician decides, that's their medical lane. I don't step on that. But what we teach is how to get to the right place safely. And so that's all on the website. And so that would be for somebody who wanted to learn just the basics of it. But here's the thing is, Colin Rigney, which I don't know if anybody knows Colin yet, but do me a favor, go look him up. He's a genius. Colin Rigney and I have developed essentially like a mentorship residency program to where you can learn all the stuff that we have online, in a structured sequence, understanding from start to finish. But we also have shadowing rotations in Arizona. So I'm a business partner in 7 multidisciplinary clinics, meaning we have PT as the front end, imaging as kind of a bridge, and then we have medical providers in-house with x-rays in-house, and we do procedures and we work all together. Now, we have those 7 locations, plus we have a variety of other physicians throughout the Phoenix area, sports med physicians, to where people get to shadow. So that's where the real knowledge comes in. We know that we can learn from a book all you want, but until you get in there and you see that's where the real knowledge actually happens. And so we have that residency program to where you still go through a structured, education, that didactic online stuff that we have, but also now you're getting hands-on treatment, you're getting hands-on education, you're getting all that kind of stuff. So I guess hopefully that answered kind of what you were getting at. Is yeah, we do online stuff, and then we've also developed a method to where, say, if you bought an ultrasound machine, all right, so you brought an ultrasound into your practice and you're doing, I don't know, the residency, or you want to learn more about MSK ultrasound, we've also developed a method to where we can see your screen as you're scanning live, and we can see from an external camera where your hand placement is. And so we can make live corrections on what you're scanning to help you make the correct diagnosis in the first place. And so that's something that's been missing. And I'll be honest with you, I kind of stole that from video gamers that were streaming.
Yeah.
I kind of reached out and said, "Hey, how is it that you're seeing the screen? I can see your face, so I know we have a couple things going on here." And so I'm not saying it's proprietary information, but we figured out how to do this with ultrasound education, and so now we're treating docs all around the nation, that have not even come to see us, and we're treating them virtually, and we're teaching them how to do things and how to get the correct diagnosis. And then they come visit us and they shadow with us, and that all corresponds with our online practice. And so that's how we've structured things.
I love it. I can go back in my content, probably it would have been pre-pandemic. So let's say late, 2018, 19. And I was saying, I can't believe that professionally we still have continuing education courses where we go somewhere for a weekend, we cram 24 hours of information into our heads and then think that we're going to bring it back to our clinic and utilize it, when I could literally be with you virtually, in real time, when with a real patient in my clinic doing real clinical care. It's just completely the way it should be done. I am
Hmm.
so impressed and so happy that you're leading the way on something like that. Because that was going to be a big question of mine, was like, can we do it virtually? Can I have it in my clinic? Now, you and I think we talked about ultrasound machines and the financial investment. What's a general idea of what something like that would cost from a hardware investment? Like, what's the price points? Give me a range.
Yeah. So from a hardware perspective, so if you're looking to get a machine in practice, there's a lot of handheld machines. And I've noticed that in PT practices, these work really well. These work fantastic. So handheld machines, I don't know if I'm allowed to say company names, but let's just say there's a few out there that have fantastic resolution. They plug right into a cell phone or a tab. I mean, you can go from room to room, you can bring it out, you can do whatever you want with it. In fact, I take these to sport events, and I do what they call POCUS, point of care. So acute
Okay.
care with sports events. And so they travel with you. So that's an option to where you're looking anywhere from $2,000, $3,000 up to like $7,000, $8,000 for these portable ones. And then you have ones that are like laptop size that still travel very well. I mean, they fold up like a laptop. They go with you. They go in a little duffel bag like your laptop would, and those can range anywhere from like 15 to 30. And so this is something that we talked about in our ROI webinar, which I highly recommend people go check out.
Is that
But
available? Can somebody register for that? Or is that only for students?
no, nope. Those are available. We put links for people. We don't give it out just willy nilly. We
Sure.
don't just give it out to anybody. It is for licensed practitioners. It's for people who would have the availability to do MSK ultrasound, with some exceptions, like maybe some business owners that have this in there. We'd want them to understand what it is. But no, it's just a quick registration, and then we'll just send you the link. But yeah, and then of course the sky's the limit with technology. There's something called a cart base. This is what you usually see into hospital systems. I mean, you're talking 70, 80, 100 plus $1,000. If we're talking about like a smaller clinic, I mean, that's overkill. And the ROI, well, I mean, you'd be working that out for the rest of your life. But the investment's not great. Like, it's not substantial. And again, in that webinar, we actually break down how many scans would it take, how many this, how many that. And if you're doing soft wave and you have a package and this is included, how many of those would how many shock waves plus, physical therapy and dry needlings? What would it take to get my ROI? What would I need? How long would it take me? And how many patients would I need to see with this service line to make my money back and then some?
Right. So let me ask you, and I'm listening to you, but I'm also looking on my cell phone. I was texting with the non-surgical orthopedic the other day, knowing that I was going to be talking to you, and I said, machine do you use in your office?" He said, "Sonosite MSK Turbo." Does that sound familiar?
That's good.
So,
Yeah. Yeah.
so
Sonosite's good. I mean, again, there's a lot of companies out there.
sure.
Most of them
What
have
what
like
would the price of something like that be?
again, without knowing Sonosite's price list, but if you're looking for, like I said, like that laptop style, you're
That's
looking
what I
anywhere
think it
from
is. Yeah.
yeah, like anywhere from 15 to 30. That's kind of that general, don't
Okay.
quote me on it, but 15 to 30 is that kind of that price range. Like I said, if you're looking at a PT practice and you're trying to get your hands dirty and try and get into this a little bit, the route of like, the Clarius or, some of the other handhelds like GEV scan, these are again portable ones that fit in your pocket. They say it's the next stethoscope. This is something that you're going to probably walk out the door like anywhere from 5 to 8. You know what I mean?
Yeah.
But buyer beware. A lot of these have cloud-based subscriptions that you'll have to pay for, HIPAA compliant cloud-based subscriptions. So just be aware that you may have an add-on on top of that, to where you might have to pay a little extra just to have that service to store all of your things in the cloud. And again, some of these machines have that virtual education built in to where they already have the service line and the technology built into where you and I could talk via ultrasound, and I could be looking at your stuff. So a lot of them are thinking forward and already putting that into it.
Yeah. Wow. Now, I want to be respectful of your time. I've got one more kind of question. Originally, my intent was for you and I to discuss shockwave therapy a little bit more, but I love all of the information about what you're doing with ultrasound. So we'll have to book another call to get into some of the other things that you're doing and other questions I have. My last question, kind of for today, is help me understand. I've heard people say they'll use diagnostic ultrasound as like a pre-test, post-test. They'll look at the tissue, look for tissue changes. When they've said this, we were talking specifically about shockwave intervention, but I would imagine you could see changes in tissue then with different kinds of interventions. How does something like this work? Can you really see tissue changes in such a short, period of time with just an intervention?
To me, if you if you add some sort of harmonics, or if you add some sort of tissue stress, are you going to be able to see some of that tissue stress throughout there? Yeah. So if you increase inflammation, things like that, there's markers that you can look at through there. And I get this question a lot, especially with like people doing orthobiologics, things like that. Is there more data coming out to see the tissue viability over time? Sure, I can't give you that answer right off the top of my head. But again, if you're seeing changes in fibrillar pattern, like the actual echo texture, like the structure of how it's supposed to look, um, in theory, and again, let's keep that very diplomatic. In theory, could you see changes? Yeah. And we have orthobiologic clinics, and this is what we tell our patients. In 12 weeks after your injection, come back, for your follow up, things like that. And if you're not feeling better, let's take a look and see what's going on. Rarely do people want to get a follow up image if they're feeling great,
Sure.
right? So rarely are they like, yeah, this feels so good, I want to see the tissue. I don't hear that very often. Usually at 12 weeks, if people are feeling pretty good, they're just like, hey, I'm just going to live my life. And sometimes they don't even show up to the follow up, to be honest, but
Yeah.
because they're feeling good. But again, to answer your question, in theory, could we see changes in tissue structure? Sure. They might be very subtle. And this would be something for a very experienced, trained eye. But if you're putting shockwave onto something, I would actually love to see more data come out on that. So I'm waiting for you to put your paper out.
All right, let's tie a bow on today's episode. So, what is the best way for people to reach out to you? Now, I'll share the website. I love your website. Great job on that. I'll share it in the show notes. I'm assuming LinkedIn is probably the preferred method. How do you like people to connect with you?
Yeah, just find me on LinkedIn. I mean, I might be surfing around some other places every once in a while, but realistically, all my good information, everything that I put out that I try and pour my heart and soul into, is on LinkedIn. There's so much information, and here, don't tell your users this, but if they follow me on LinkedIn and just watch all the stuff I'm doing, I mean, realistically, most of my information is on there from my
Yes.
websites
Awesome.
and stuff. No, we always joke about that is we give away so much free content, that's not the point of what we do. So
Right. Right. Well, Ryan, thank you so much. Don't get off the line, but thank you so much for joining me today.
thank you. Thank all your viewers. I appreciate you for putting this out there.